ನಿಶ್ಚಿತ you can mute YouTube mute ಮಾಡಮ್ಮ. So good evening all. I think we have 13 people joined. Dr. Krishan, are you there?
Yes, sir, I am here.
Can you please check your screen? Good evening, Dr. Jalil sir. Dr. Anil Lamba sir. I'm in coming from St. John's, Bangalore. I'm traveling. Dr. Krishan, you can ask
Yes,
for
sir.
the.
Yeah, I
sharing the
have
screen.
requested. I have requested.
Yeah.
Good evening,
Just,
everybody.
Good evening, madam.
Yet I haven't got the share permission.
Go to the share button.
No, sir, not there.
Share button is not there.
I'm not able to share. The host isn't allowing sharing for this meeting. So
No,
they
I
haven't
will.
a host. Yeah,
Nishita,
I have just got notification. Yeah, they have made this.
Yeah.
Yes, sir.
Kishan, as much as possible, you cover pediatric ENT and allergy. Don't worry about ethics. Okay. If time 9:15, 9:30, hand over to Nawaz from a digital AI powered digital stethoscope. Okay.
Okay, sir. I'll try to do it this in 25 minutes and
Possible you
30
finish
30
off.
minutes.
Otherwise,
Yeah.
don't worry. Huh? Okay. We'll finish the specialty first. Then we will see the others. Okay. Let us not be in hurry. We can have one more session, maybe after 1st of July. Huh? No issues.
Should I start, sir, or?
Yeah, you can start. Just to tell you, Dr. Krishan RAJBHAR is a AI-enabled ENT specialist from Delhi. Last 2 years, I know him very well in Doctors A conference and various forums. IMA and all is giving talk, and he is representing all the legality issues in the Supreme Court. And he is going to tell you about mainly the specialty aspect of AI in ENT, pediatric ENT and allergy. If time permits, he is going to cover up ethics and regulation, because he is one of the best person who knows each and everything about the regulation aspect of the IE. Over to Dr. Kishan.
So thank you, sir. Good evening, one and all. So today we'll discuss this artificial intelligence and machine learning in this pediatric ENT and allergy. So I'll try to skip those all things which have been discussed till now, because there has been a lot of discussions, a lot of aspects of AI has been covered. So I'll discuss those things only which haven't been covered. Or if you feel you want to stress me, please feel free to unmute yourself, comment, say or comment in the chat section. So before starting, I like to give a this is something about me. And before starting, I like you all to please tell me what are your pain points in pediatric ENT and pediatric allergy. I like the people attending, please put in the comment section what are your pain points, so I'll be focused towards that only. And I think for this question, who has used ChatGPT in clinical practice, there will be hardly anyone who hasn't used. So what my focus here will be to change the way in which you are using ChatGPT. So please, I'll give 30 seconds to you all. Please put what are your pain points in the pediatric allergy as well as pediatric ENT.
Unmute yourself and please tell. No problem.
Yeah, you can unmute also.
Quick diagnosis and treatment plan.
Okay. So quick diagnosis and treatment plan is one pain point which we can solve with AI, effective use of AI. Any other pain point? Anybody?
Yes, compliance by the patient.
Okay.
Yeah,
so
sir.
we want to
Hearing
improve the
assessment. Yes, sir. Yeah, hearing assessments.
Yeah, ma'am. That is one very common actually, and our government is also focusing a lot on hearing assessment, neonatal screening, and all, where AI can help a lot. Any other pain point?
No, in allergy practice and asthma, where I'm practicing, I've been using
Yes, yes.
the chatbot Go, where I make use of it. Sometimes instead of me spending time in going through the report, especially the effort is the latest one, and sometimes the CRD also little complex. So what I
Okay.
do is I've fed my AI. Customized chat PD, which will programs and gives me result, and also it also gives me a parental education aspect. That's very very impressive. And
Yes,
also
yes,
in
sir.
follow
That
up
that is
also, yeah, in follow up also, I'll compare their previous report and the present one and show the improvement to them. So that's what thought little bit of time consuming for me to do all that, because I'm not supposed to reveal the identity. So I need to take a extra work, like taking a screenshot and fitting it to my thing. It will take little extra
okay.
time, but it's worth doing it. So
Yeah.
parents will be alert to be in follow up. So adherence has become much better.
Okay.
Complaints from
Nice.
the parents become much better.
So, sir, here I would like to tell one thing. You can use patient de-identification tools, which we'll share in our medical legal regulation session.
Mm.
So we'll discuss those aspects also. That will increase your speed also in this.
Yeah, yeah.
So
If you can share in the WhatsApp group the tool, we'll just try to
yeah, yeah, sir.
go through
I'll
it.
share in the presentation also. So
Mm.
I have all the free, at least open source tools that we have.
So
Uh,
only thing is we do customized chat GPT. We should give a good reliance resources so that it will not hallucinate.
yes, yes, sir.
Yeah, yeah.
So we all know that there is rising allergy burden due to urbanization, and even urbanization of the rural area. We are having rising allergy burden, and there is delayed hearing loss diagnosis and all, and that is causing a decrease in IQ and further repercussions on the kid. So these are the pain point or the challenges which we can solve with AI effectively. So AI can be a very helpful technology in this, as well as food allergy, which was prevalence was 2% in 1950. Now it is more than 7%. So that is also one common pain point. So these are the common things which we can address effectively using AI, but we have to use AI effectively. So in allergy or in any specialty, we are talking about uh, personalized medicine, and precision medicine. So I think you all are knowing what it is. So I would like to ask one question from you all. Have you personalized your AI tool? Whether you are using Gemini, Chat GPT, or Claude, have you personalized? Anybody who has personalized their AI platform or AI tool, and how you have personalized? Please, you are feel
Oh,
free.
what extent? What no, no? What extent you mean by personalized?
Sir, personalized means whether the Chat GPT or Claude or Gemini is answering considering who you are. Means that AI tool is knowing who you are.
Yeah, yeah.
Have
That
you?
way that I have done in my chat GPT when I'm giving my report to the
Okay,
patients. Yeah, there my clinic logo and my name will come out there at the end. So the report is prepared by so and so doctor. All that will be there, and it also identifies who I am because it has learned over the last 3 months. It has learned who I am, so it knows
okay,
all my caliber. It knows all my abilities. It knows my interest, and also it keeps reminding me. Also, in case I'm little deviating elsewhere, it tells you this suits you, this suits you. And also, it's supposed if I give some other topic in that, it also tells me with my background of allergy and asthma, it tells where I am, how much
okay.
I can deploy
Yeah,
other
yes.
system into this.
Yeah. So other than this, one easy way I'll show you before I proceed, because we are talking about the uh, personalized medicine. So we should know how to personalize your AI tool. So before proceeding, I like to show you one easy way to do that I have done with my all AI tools. I'll show for Chat GPT, but similarly is for all others also, Claude and all. So just go to the settings, or I'll just go to the settings, and in the setting profile, you will get a uh, personalized options. So I'll show. And there you can tell about yourself, who you are, and you have to do this settings once before using any particular. Suppose you are starting using Claude from today or this, and you will do it will, you don't have to prompt, or you don't have to give the context every time. It will remember like this. So this is my, in personalization you will get a custom instructions. So I think you are able to see my screen. So here I have mentioned everything about me, what I am doing, what is domain of my work, my medical legal thing, AI thing, my ENT allergy and all, everything. So I practice pediatric allergy also. So these are the things I have given the prompt and what I expect from that AI tool. So in this way, it is one easy way in which I think this was not discussed till now. I hope that's why
Yes.
I suppose you are talking about custom GPT.
no. Custom GPT is separate thing. This is
This
personalization in the
personalized.
settings. Custom GPT, yeah. Custom
Doctor,
GPT is separate thing. We'll,
yeah. Dr.
mention
KRISHAN,
when.
yeah, could you
Yes,
please
sir.
go from the beginning and use your laser pointer, because that's not visible, the one which you pain. If you can use laser pointer, better.
Which cursor you want to say about
Yeah.
cursor or?
No, cursor. No, go from the beginning, no, step by step, so that we'll have one more idea.
Okay. So just you have to go here, go to settings. I hope you have got this. Go to setting,
Yeah.
and here you have, there is an option called personalization.
Okay.
Personalizations, you will custom instructions.
Mm.
So you can create your own custom instructions that as I have created based on my profile and my work and what I expect from this AI tool. Just give the instructions till and save it, and it'll follow that. So this is one way.
No, you mean to say this personalized settings? We do it once. So
Yeah,
whatever
once
whatever.
do this once before in the beginning, or if you haven't done, you can do right now means today, and this will be there for every time you use that.
No, not you mean to say this holds good for all other customized GPTs?
Custom GPT is separate thing, sir.
No, I
That
got
we create
understood.
for we
Understood.
create for task based, but this
Yeah.
is for any search. For example, I am searching here, so it will keep remember the context in which I am searching. That based on my profile, it will give the output.
But it can
So-
also be implied to the customized GPT also. No, that can take up who you are, everything, isn't it?
Yeah, that will be applied. But in custom GPT, generally we give separate instructions in the settings. So that is
No, we give separate instruction, but it will know who you are. No, our identity.
it'll know.
Yeah,
Even in
that's what.
custom GPT will. Yeah. So this we have already discussed. What is AI and machine learning? So we are not going into detail, but this ecosystem flowchart, you should remember that at what all level we have the flexibility to use AI for the benefit of the patients and for easing our work, like patient parent. So with the advent of AI, we are moving from reactive to a proactive healthcare. Proactive healthcare means you are seeking healthcare assistance, healthcare help before the symptoms comes. Means based on some parameter deranged or something like that. Like smartphone wearables give you data and that AI analyze it, then physician review it, then we come to the clinical decision. So this is a whole ecosystem in which we can work, even in the domain of pediatric ENT as well as allergy. So these are the areas where we can intervene. We can use AI. This is one example I have given a kid. So like AI risk predictions and home screening, like AI analyzes environment and wearable data to alert parents before symptom becomes severe. Means before the kid develops the symptoms, we are intervening. We are seeking any help like that. So it also does a smart trials and pre-visit summary. So AI stratifies urgency and prepare clinical dashboards so doctors are ready before the visit. So in this way, we are moving from reactive to proactive. Similarly, these all things has been stressed upon multiple times, like the assisting clinical consultations, documentations, and even diagnostics. Like in pediatric ENT, it can help in interpretation of complex audiology as well as endoscopy. Similarly, remote recovery and smart follow-up, remote like AI monitors post-treatment sleep quality and health for the patient of OSA if the patient has adenoid and that is affecting his or sleep. So from reactive
But,
to predict
but
to
Dr. Krishan, could you please
yes,
tell me how is this going to help us before even symptom appears? See, the patient has to approach us, not before the symptom. Only when they get symptoms, they'll approach us. But how will they
yeah.
approach us?
So yes, sir. So earlier, we a patient used to approach when the symptom used to appear, but now what is happening? Patients are using various band like there are many companies now. I am talking about not for others, but for allergy and pediatric ENT per se. Like there are companies like Clinic Key and all. They are doing vitals monitoring. They are doing like suppose one of my patient is allergic to some pollen and the it is integrate his smartwatch or his smart band is integrated to the weather data and the pollen counts are there and the patient is expected to have some symptoms, so like that they can approach. Similarly, if their vitals are are going beyond threshold, they are even in other specialty patient also like cardiac and all, so their the vitals will change beyond a suppose threshold, then they can it will give the alerts to their health counselor or parents, and then based on that they can take consultation, they can take counseling or consultation from the healthcare provider who may be doctor or not or can be paramedic or
Oh,
like that.
so you mean to say they should be on the monitors to pick up this some
On health band,
parameters? Health
like a
band.
smartwatch and all like that.
Oh, okay, okay. Intervention required.
Yeah. So from reactive to we are moving toward predictive, which is preventive, personalized, participatory, and population based. So we have to see this. So like there are many tools. I'm not going into tools because that will unnecessarily overwhelm us. At the end, I'll show those FDA approved tools only, like TytoCare. So this is a kind of portable otoscope integrated with AI that gives the diagnosis. Many a times, some confusion endoscopy images or otoscopy images are there, or many a times we are not able to interpret. So that helps. And similarly, like here, X and shoebox. So these are FDA approved. So these are in screening for hearing loss and all. Similarly, like voice disorders, voice biomarkers, like uh, it from the laryngoscopy images, it helps to interpret the cause, whether this is a vocal nodule or even change in voice. It is so there are models that help in this. So this is one example which I have a portable endoscopy system which helps. Similarly, there are tools like Night Owl and Sunrise platform. So this is integrated. This is a smartwatch, sorry, smartphone integrated that catches the sound of snoring and other sounds, and basically the change in frequency of the sound. It catches and thereby it acts as a. It is not a diagnostic, but it's a screening kind of thing. So similar, but there are many catch to it that ambient sound, like sound of the fan or sound of the outside traffic, can interfere with it. But we are in the process of developing those things that is canceling those ambient sound, and they are more effective. But still, it is for screening only, not for diagnostics. Similarly, skin prick test. So I think many of you might be doing skin prick test in your centers. So in interpretation of skin prick test, subjectiveness comes. Many a times, what may be 7 mm for someone will be 8 mm for some others. So and if we are planning immunotherapy for that kid, so that can bring a lot of change while those calculations. So in that AI helps and the computer vision helps. So even if you de-identify the skin prick test findings with a good camera and put it any custom GPT you have created for that, it can give you good results. So I use it in this way, and consequently the clinical decision can be made accordingly. Similarly, this one I am working with the one pharma company. We are planning we are designing, basically we are in the process. We are designing an app that takes the pollen calendar. One hurdle in this is our country doesn't have updated pollen calendar, so we have to correlate with the roughly with the weather. But if any particular country like Western world have their regular pollen calendar, so they can fetch the data from that pollen calendar and give the pollen prevalence, pollen amount, and that can, if suppose some patient is allergic to that particular pollen, so that patient can get alerts on the app. So this is one way in which it can help. Or even if you don't have app, we can correlate this on a simple chat GPT if we have prompted properly. Similarly, like many a times as an allergy practitioner, if we have like we are not sure whether immunotherapy will be very effective or how much effective it is. So in that, personalization help, like digital twins. Digital twin, we test the based on the parameters of the patient, we test that particular treatment like immunotherapy in that patient, and then give to if we are giving good result, then only we are giving in real patient. So that can also help. So this is one domain which that works. So you might be aware about this platform Pandomics. So in this, what they have done meta-analysis of 1200 plus patient cases, and they have tried to find out the genotype or the genetics which is responsible for this disease. So they have discovered 11 commonly dysregulated gene targets, and consequently they have targeted that for the treatment. So what this has done, this has increased the pace of therapy. Means earlier the drug discovery was taking a lot of time. So this is one thing. Through using AI, we are moving towards personalization in the allergy. And allergy is one domain. Every allergist will feel that still we are not able to manage allergy in the way we are, because there are a lot of data points, and to analyze that data points is practically impossible from human brain perspective. We need some computational power which comes with AI. Similarly, this is one platform. This is a kind of chatbot which is for urticaria support. So ADAS is that. And when comparing with the general LLM, the clinical accuracy of for this was 94.6. Similarly, beyond this, where AI can help in clinical decision is precision chronotherapy, like giving the medicine at right time. That is one important. Maybe you are giving you have diagnosed correctly, you have given the right drug to the right patient, but maybe not be the right time. So here the precision chronotherapy comes into role. So here are example, we are not going to that. Similarly, the precision economics. So these all things where AI analyzes a lot of things and can help in better decision making. So this is one chatbot which I have developed for counseling purpose of my allergy patients. So similarly, chatbot can be made. If you haven't made for yourself, you can make it. This is the FDA validated tools for various things. Many are in the various stage of approval only, but yeah, Taito Care is one, ERX is there, Shoebox and Night Owl I have mentioned already. Similarly, for the compliance part, we are now having smart inhalers. Even Cipla is working on that, bringing smart inhalers. That there is one cost angle to it that is only restricting the Cipla, but Cipla is actively working on bringing smart inhalers to India. So that will be very active in improving the compliance of the patients. What I was talking about, the project which we are doing, we are trying to improve that compliance perspective from the nasal spray. So we have integrated these all things in that app which we are designing. Similarly, spirometry. So where AI is, as sir was already saying, that AI is very helpful in analyzing or analyzing the reports and all. So like complex CRD reports can be analyzed. Similarly, I use AI to, after de-identifying the patient data, I use for understanding the, as I have my sleep practice also. So I analyze for understanding the polysomnography, PSG report, sleep study report. So many times it take a lot of times to analyze a sleep study. So here, there with proper prompt, AI does very good. So related to as we had already discussed, notebook element all can be very helpful in devising in planning a proper counseling strategy based on the report of the patient, whether it is CRD report or patient skin prick test report or sleep study report and all. So these are the things I think you all have done till now, how to give prompt and all. Few things related to the prompt I'll discuss in the medical legal sessions, how your prompt can be medical legal effective. So there is one thing which already has been discussed, that there are simple prompts. There are simple prompt and system prompt. So simple prompt is like just giving a prompt, and that is equivalent to the PG first year. I think this has already been discussed in a previous sessions, but I'd like to re-emphasize it. Similarly, for the allergy practice, you can use all these level, but it's not that directly you will jump to using Claude skills. You have to go through these all levels. Once you are thorough with simple prompt and system prompt, then you can start learning Claude skills and this multi-skill orchestrations. If you want, you can take the snap of this. This has summarized everything. So making a custom GPT for patient counseling, for counseling your patient before getting skin prick test. So there are a lot of domains in which you can use custom GPT for counseling part as well as your planning. Like I have made custom GPT for my surgical planning of the patient. So that can also be effective for my pediatric ENT patients, when I am planning for adenoid, when I am planning for any sleep surgery. So we do, like there are a lot of things, a lot of domain in which we can work. It's all about how much you can think and apply. So these are some use cases where we have already used what I have discussed. Similarly, Claude skill is one good thing. But yeah, if you have been thorough with your simple prompt and making custom GPTs and all, then you can move over to using Claude skills. And even in a case like in a subspecialty like allergy, where many a times diagnosis is also a challenging, where Claude skills can help. Where you can many a times patient doesn't come with only one or two symptoms; they have multi-system involvement. And nowadays, whole fraternity is moving towards they are of the opinion that sleep and allergy are intimately related. A patient with sleep disturbance will have a high chance of developing allergy. Similarly, a patient of allergy will have a chance of hampered sleep. So in these kind of thing, to counsel the patient, to manage the patient, we need some here the Claude skills and multi-skill orchestrations can help a lot. And similarly, notebook LM can be helping updating ourselves. There are a lot of guidelines which we routinely follow in our allergy practice, YAKI guideline and WHO guidelines. So these are the things we this is briefly I have mentioned about the precision medicines, how that can help us in practice. So precision is not only AI, it's all about what we are routinely doing, and we have to be careful. Like precision chronotherapy means we are giving the right dose to the right patient at the right time. That is important. Right time is important. So this is all. So now we are like merging genomics and health record data and imaging and all to multimodal learning for our decision support. So, real-time pollen forecasting and symptom tracking via the variables and all. So this is one domain in which we are working. Soon will come with the solutions. So like patient is traveling from Delhi to Bangalore, and she is allergic to that particular pollen, and patient get the alert on the app that pollen prevalence or pollen concentrations in Bangalore is high, so they can take precautions in advance. So like that, these things can help. Otherwise, the thing is same, that your custom GPT for counseling, for planning treatment, these all things helps a lot. Even for the decision support, many times custom GPT helps a lot. They are my mentors whom I have learned allergy. So any question we have, we can take in the end. I'll start my medical legal thing because I have. As we have time, so we'll start.
No, till you what you have sensitized about usage of AI in our practice, but some one example and with hands-on practice would have benefited us. Because you
So,
told
sir,
so many things, so many tools you said, so many tools can be applied in our practice. But how
yeah.
and when and possibilities?
So, sir, actually, like for endoscopy images, suppose you have got. So, do you do otoscopy in your practice?
Yeah, we do otoscopy. Yeah,
Yeah.
something.
So, so if you have endoscopy system, you have like portable
No.
otoscope
No.
image is there. So,
Only
yes.
otoscope you can do it, and hand
Okay.
otoscope. Yeah.
Yeah. So based on your use cases, there are like uploading imaging and prompting, like uploading the polysomnography image or skin prick test image.
Yeah,
That can be done. That can be uploaded on
yeah.
your
Say for
custom GPT.
example, skin prick test. You said, how do
Yeah.
you take a photo of that, and what are the values you're doing to tell the thing about
Yeah.
foreign
So,
photo?
so, 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 so how I do after doing the skin prick test, and at the time of interpretation, I take the photo, I upload in my custom GPT, which I have trained basic training, like how to report and all the protocols I have been uploaded that you can do, and many a times protocols also vary from doctor to doctor. So uploading and after uploading, after I what I do, I in the image before labeling also, I just give a random number to it and then give the prompt to it for the interpretation, that please interpret regarding the finding and all. So for example, for skin prick test, if the proper house dust mite finding is 7 like that, so they do the reporting, and if there is erythema or pseudopod, it also documents that, so that helps a
No.
lot.
Regarding the measurement, will it take measurement once you feed the photo, or do you have to take
Yes, yes, sir.
measurement? And,
Yes, sir. Even if Chat GPT with proper prompt gives almost correct measurement.
and
Even
measurement by
custom GPT will be better, but even random Chat GPT will also be good.
okay.
Krishna,
These are some use cases.
Krishna, can you show us the AI-enabled otoscope which you use for pediatric patients?
So I have a demo video, sir. I'll put in the group, but right now actually I haven't connection with the my system. So,
Okay.
but I'll put a video of it in the group. I think that will be helpful.
Which can be used for pediatric also.
Yeah, pediatric also.
Because most of the adult, that otoscope, that thing is not able to put it to the ear. The endoscope, you are not able to put into the pediatric ears.
No, sir. Actually, we have this is what lesser diameter endoscope also. So the attachment, we can attach all endoscopes to that. So the photo which I have shown you now, the next to that is mine only, and in that we can attach everything. So thinner endoscopes and all everything.
Yeah, I've been practicing
0.7 mm.
using otoscope more than 25 years. What I found in newborns, we were not at all able to appreciate the eardrum at all. Only when just by baby crying with wincing, crying with the tenderness, we assume it to be otitis media. Otherwise, I have not seen the tympanic membrane of a newborn, at least less than 3 months. I don't know whether I'm not able to pick up, or is it the same thing with others also?
Dr. Gnana, you are right. Most of the time in the children, we see a lot of wax also. But
No,
anyway,
apart from wax, even if they don't have
you are
wax
right.
also,
That is ear canal is narrow, and many times in otitis media there is also some component of otitis externa or some inflammation is there. So in those patients, it is difficult to negotiate scope. But yeah, that I don't have that problem while examining those pediatric patients.
Dr. KRISHAN, the difference between
Sir, can
ENT
I ask a
surgeons and
question?
we as
Yes,
pediatricians is that we use
Sir?
a routine otoscope, but we
Yes,
we can't take images. So I don't think we can take AI help for interpreting these images because
Sir,
yeah.
Sir,
there
can I
is
ask a question?
endoscope coming, which is I close one device.
No,
So,
he's
sir,
talking about endoscope.
what we can
That
do,
is why.
It
we
comes
can take
around
questions after
1100
15
rupees,
minutes
and you connect
because
it to your mobile Android or whatever it is. It will give you the full view, and you can download save that image and upload in your whatever thing you want.
there are a lot of things coming in 600, 700 rupees. Even Portronics is one good, that portable endoscopy or otoscopy system. So there are a lot of things, Chinese things also coming, and that is very cost effective also and can be used
Okay.
better than otoscope actually.
No,
How we
that,
do medical grade, we use medical grade endoscopes, but those are also very effective.
no, that KRISHAN, I have got 2-3 units, but let me tell you, I don't know. I am not able to appreciate the eardrum of a newborn or less than 3 months. But little bigger children, yes, I can see. But I have got 2-3 units with me, but unable to see view the eardrum of a newborn.
It's true that lower age group we have to fight with the child. It's a big fight, I think. It's a struggle.
Beg your pardon?
We have to struggle in the kids, a smaller age group.
Not struggling, not possible to view.
Yes, that's what I'm saying.
Sir, can we have a discussion after some time? I have this medical legal regulations, and I have some time, so I wanted to discuss this before finishing these sessions. So, regarding the medical legal and ethical regulations of artificial intelligence and machine learning in Indian healthcare. So, this I start these sessions by quoting this, that AI will not replace doctors, but in quote, AI may redefine what standard of care means. So this is one thing which I am stressing in all the medical legal conferences in which I talk about this AI and all, that it will for sure increase the standard of care, because earlier what was not expected from doctors, that this is not human, this is not expected from doctor. With the use of AI, it has become very very easy to do a lot of things. So consequently, judiciary will also recognize that, yeah, this is expected from a normal registered medical practitioner or normal doctor. So if you are not using AI, anyways, the standard of care expected from healthcare from doctors will be more. So if you are not fulfilling that, that will be a breach of standard of care. So consequently, AI is increasing standard of care, and we have to keep pace with it. So having said that, we'll see what are the reasons for medical legal regulations of AI. Why AI is susceptible to more medical legal risk compared to other technology or other things we have, like clinical examinations and all. So, like data to design, like if AI design is biased, it is being biased to some particular population, or so there will be sample biases and lack of representative data sets, and that discrimination will come into output also. So that is one thing. Similarly, design to use, like bias deployment. We all know that technology, if we'll see from the angle of social aspects of any technology will be the deployment, the distribution. If we see for any green revolution or anything, is also depend on for where fund allocation is there. So if the distribution is inadequate or is not equal, so the it will be biased. Similarly, used to world, like application in justice, like it is used in this particular part of the populations. World to data, right? Real world patterns of healthcare inequality, like if a model is trained on western data, so this will not equally represent. So while using any AI technology, we have to look for sample data on which it is trained. So like noise and artifacts in clinical input and measurement can simulate data shift between the AI training data and real world clinical data. For example, that training is on western world, western skin color, and we are using for doing derma diagnosis of South Asian or global South population. So that is, there will be false diagnosis, and this false diagnosis will lead to medical legal risk if we haven't followed due precautions. That why human in the loop is all there. So healthcare AI is considered as high risk AI. So for any such things, we have to be careful. We have to observe, always monitor the things and all. This is one example that most of the RCTs on AI is being concentrated in these two countries. So consequently, the training data set will be from these two countries. So without sandboxing means regulatory testing on a local population, AI molecules should not, AI technology should not be used. Similarly, there is one term called subgroup analysis. Like particular AI technology may be very helpful in diagnosing particular set of disease. So we have to do subgroup analysis. For example, here this is from one paper that large hemorrhage more than 5 mm, AI missed 51.5%, but human radiologists missed 27.6%. So for this group of hemorrhage, I'll use this human radiologist will be preferred. Similarly for others. So these are the things in which we have to be careful. I'm not going into these details, but we'll see what all we can. This is one real time. You can take a snap of it. This we should not do while using AI in patient management. Never upload any PHI. Treat AI output as a second opinion, not a definitive diagnosis. Document the AI. Explicitly note in the EHR when an AI tool heavily influenced the decisions. This helps us in the code of law. Demand transparency, reject black box tools and all. Use approved system. So we'll see where we have to see CDSCO, FDA approved or CE certified. Audit locally. Monitor performance on your specific hospital because that AI model may degrade. There may be model drift. Maintain the loop, obtain informed consent. That is important. I was the first prominent in our country who has stressed on taking consent. So when we were when we are framing guidelines for safe AI in healthcare, many lawyers from Supreme Court were not of the opinion of taking consent in using AI because they are of the opinion that doctors are already burdened. But I felt, and later in the guideline we have drafted this, that consent has to be taken. Validate subgroups. So subgroup analysis is very important, that I have already stressed upon. So regulation should not be seen as a burden on us. It should be seen as a engine of trust. This has been already discussed, so I'm not going into detail. Now we'll see what we have to see. Like physician retains the final clinical decision authority, like whether the AI recommendation is right or our clinical experience is suggesting something, and we have to document. If we are going against the AI output, we have to always document this. On based on what reasoning we are of the opinion that we are following things which is not as per the AI output. That will save us in code of law. Similarly, hospital has vicarious liability whether the healthcare staff are trained in using that AI technology or not. If hospital hasn't trained them, so hospital will also be vicariously liable if some mishaps happen. Developer has the responsibility for being accountable for algorithmic accuracy whether safety testing has been done or not. So this is one thing. Now one question to you all: what do you think is most punished, maximum punished by court? Blind reliance or blind
வந்துட்டு இருக்கீங்க ஹலோ
while blind reliance or blind
எங்க வந்துட்டு இருக்கீங்கம்மா
applications?
எங்க வந்துட்டு இருக்கீங்க
So here I have mentioned that blind implementation is very court punishes to a
சரி
maximum extent.
கடலூர் கர்நாடகா இருக்கீங்களா அப்போ
I'll request everyone to please
mute.
சரி சரி சாப்பிட்டம்மா நீங்க சாப்பிட்டீங்களா
So blind implementation, court considered this as highest legal risk because reckless adoption of public AI tools without establishing SOPs and all. So this has a chance of doing maximum injury to the patient. Similarly, blind rejection is having lowest risk. So we have to remember that court do not punish AI use; they punish the loss of clinical judgment. So we have to be mindful that there should not be the loss of clinical judgment. So we'll see what we can do. Like in this case, the WhatsApp privacy breach, patient de-identified the photo of trauma injury patient in a closed group, but the background identified the patient and all. So this carries and this indirectly is breaching DPDP Act and all. So we have to take care of this, that never upload raw patient records to public AI platform like ChatGPT or Claude. Never allow an AI tool to be the final decision maker. The human in the loop or human over the loop should always be there. So these are things you have to, these are the guardrails we have to take care. Radical de-identifications. So these all things has to be removed. Human primacy. The human clinician must verify AI outputs against the standard medical literature. That's why RAG and all helps. Transparent documentation. So that is very important. Even if you are not following the AI output, you have to document why you are doing this. This will protect you on the code of law. Maintain the audit trails. So that is the thing. These are the patient de-identification tools that is open source and commonly used. I use few of them. So these you can use while doing the patient de-identification before putting the for any opinion or on a public platforms, open source platform. So this is for if you want to be medically safe, this is a hallucination safe prompt. So I have tried to include all the things. So your prompt should be like this. You can take a snapshot and use it, and this will make the prompt medically safe. So you have learned the prompting for a long time in this course, but these are the set of things which will make it more medically safe. These are the ways in which hallucination is reduced, already discussed. Similarly, like custom GPT. So custom GPT, we have to give a proper instructions to the custom GPT. Suppose I have made a custom GPT for an allergy patient, for allergy diagnosis, and the patient is, I have put this QR code in my clinics or my OPD paper that which I normally do, and the patient is scanning it for some gynae problem, and patient is suffering some damage. So I'll also be accountable for that. So we have to put a disclaimer that this is for ENT allergy, vertigo, and sleep, which is my domain of practice, like that. Similarly, maybe for your domain. So like that this is one disclaimer you have to put. This I have mentioned here, this slide that is mentioned. Similarly, the custom GPT is designed exclusively for ENT allergy, vertigo, and sleep. It should not be used for diagnosis or management of conditions outside these specialties. And these things, if you have made for the counseling purpose, you can always mention. And it is safe to mention that this doesn't substitute the professional healthcare, professional medical consultations. That will protect you indirectly, because patient may consider the custom GPT answer as their medical consultation. So the AI tool is intended only for educational and clinical support purpose. It doesn't replace professional medical judgment. Final clinical decision must always be taken by qualified health professionals. So you should mention these with every output. In custom GPT, patient should get these all things. Like I have mentioned that you should not use those tools which are not FDA approved or CDSCO approved, from the point of privacy issues as well as from the output issues, that they might not be, because if you are using platforms or tools which are not CDSCO approved or FDA approved, you may land up in code of law if some mishaps happen with some patients, because that will consider as a negligence. So before using any tool, always check on these platforms. These are websites in which on a real-time basis, means they update, like for today, they have updated till 14-15 June. So just 7 days back, you can check all the approvals, all the tools which have been approved. So like AI trust checklist, like data check, pediatric specific training data, whether model which you are using has been trained on pediatric data, and all these all things. Model behavior, whether it's changing, there is model drift or not, whether model is worsening with time or not. Clinically fits the clinical picture. Child look out means always you have to use your brain also along with the output. If it is matching, then only accept it. Otherwise, no one will punish you for not following AI. But if you are doing anything which is against the protocol or which is against the standard of care, you will be held liable. So that you have to always keep in mind while using AI. So Similarly, many doctors are now using AI for social media content, for making reels, for making patient education videos. So always put one disclaimer that you have to follow the NMC professional etiquettes, or what are the rules which is in your state or as a country as such. So that is important. And this is that I use in my social media workshops and all. I teach in social media workshops. But yeah, that you have to take care that you should not breach anything, like for making patient testimonials. If by chance you are breaching any NMC professional etiquettes or rules, then you are in trouble. So these are 10 point safe practice standard which you have to follow, or you follow while creating any social media education content for your patients or public. So try to follow this. So always law remains behind the technology. This is the thing. So I'll conclude by saying that the greatest risk of AI is not that machines start thinking. It is the greatest risk is that clinicians stop thinking. So we should take care of that. We should not stop thinking while using any AI. So in future, the litigation is not the that did AI fail, but did we create systems where humans stop thinking? So this we have to take care of. So this is all. Any query or any clarifications, comment, please?
Dr. Kishan, it was too rapid fire. And if you can briefly tell us about what are the various acts which govern, AI healthcare in India.
So there are a lot of acts, but meanwhile, one is DPDP, other is IT Act. So these are two things. If I'll say you, if you have to follow two things, DPDP Act and IT Act.
Okay.
Can you please upload your presentation and any other presentations on the EPDP and the IT?
So ma'am, I have a detailed presentation on DPDP Act, but for this short period of time, I haven't used that presentation. Otherwise,
No,
in my
if you
medical legal
just
sessions, I discuss DPDP in detail, but only 2-3 things that has to be taken care. Never upload patient uh, patient health identifier, personal health identifier, PHI. And for that, you have to use de-identifying tools. So in this presentation, what I have done, I haven't talked about any legislations, any rules, which I normally I take these sessions for full day for medical legal consultants and lawyers. But here, what I have seen, what we can do as a doctor in our setup, in our clinic, in our hospital, use de-identification tools, give proper instruction to the custom GPT, which you are using, and follow medical legal safe prompt, which I have already shared, the hallucination safe prompt. Fourth thing which you can use is follow all the guidelines while using AI to create any social media content. These 4 things, if you'll use, I'm not going into detail because there are a lot of ifs and buts, which I'll be able to discuss if I get 1, 2, 3 hours for these sessions. But if you want to read, please read DPDP Act. One thing if you want to read.
Can you please upload your presentation so that we can read it later in a more relaxed way, and then maybe...
Ma'am, I'll share the official guide document of DPDP on my DPDP presentation. That is more useful.
Okay.
So there is one PPT by me on only DPDP Act. I'll share that. That is more useful compared to this.
But this presentation also, because we have heard you, so we will be able to understand.
Sir, custom GPTs, they hallucinate. How to prevent that?
So, sir, as I have mentioned in my last few slides, the hallucination safe prompt, or like custom GPT also hallucinate, but it also depends on how better we prompt. There are ways only to reduce it. We can't be sure that it is hallucination rate is 0%. We can't be that, but there are ways to do that, like proper prompting, RAG and all we already do. And you have to put one thing: do not say if you are not sure. Do not fabricate. These kind of lines, which I have already mentioned in my hallucination safe prompt. So I think if you are doing this, the chance of hallucination will be negligible, but we can't reduce it to 0%.
How does
I think
personalization differs from custom GPT? Please explain. Once.
I think, dear learners, since I am traveling, I request you to please keep your chats in the WhatsApp group so that Krishan and myself will upload you more about DPDP Act, Sahi and both, all those things. We are going to send you the PDF. If you want, we will have one more free webinar session, maybe after 1 week, so that you people will relax and listen. I think I should thank Dr. Krishan Rajbhar for engaging you for 1 hour more than on ENT aspect and allergy aspect of AI, how to use the AI tools, and also some medical legal aspects. Thank you, Dr. Krish. Now I request the person from Ayush Sync, Mr. Nawaz. Can you ask for the sharing the screen for demonstration of AI-powered digital tool? You have Ayush Sync stethoscope, digital stethoscope.
Yes, sir. Yes, sir. Hello, good evening, doctors. This is Nawaz from IU Sync, digital stethoscope from IIT Bombay. Deepak, sir, I'm trying to share my screen, but it is showing it has been disabled by the host. So, can you please allow me to share the screen?
You ask, our staff will do in my studio. I'm traveling.
Yes.
Please ask.
Okay. Any staff that is, please, whoever is listening, can you give me the permission to allow my screen, please? I'm sorry, but I'm still not able to share my screen. Can you requesting again? Can you please allow me to share my screen?
Deepak. Deepak.
Sir, you
Deepak is
can
the
call
host, so he can
Deepak
do
on
it.
Yes.
phone, sir.
Yes. Now,
Deepak is the host, so he can do it actually from his
yeah.
mobile also. Probably he's not connected now.
Deepak.
I think he is not available. He is in the meeting, sir.
Awaz,
Yes, sir.
somehow just give me 5 times. Just will allow Dr. Gurunath present. Please wait for some time. After resisting, we'll try to give you the host. It's not
Definitely.
coming, it seems. I'm asking my staff.
Sure, sir. Definitely, sir. Sure.
Dr. Gurunath, sir, you asked for the sharing the screen.
The same thing. Host is not allowing. That is the message.
Deepak, if you are the host, you can do it. Go in the share and allow everybody. Because this shows that you are the only host. There is no other host here.
Yes. Deepak
is the only host. There is no
Yes.
co-host also.
Sir, I am outside. My staff are doing, they are sharing. I am also logged in through the other account. Just wait for 5 minutes. I will do.
Is the meeting on?
Everyone is waiting, sir.
Yeah,
Deepak.
there's a deep silence. Disturbing. Dr. Palani Raman, can you tell us about
Yes.
what endoscopic otoscope you are using? He was talking about some 700 800 rupees.
But those things and all that, particularly when you are using for the our pediatric years, it's very difficult to use it. Very
Yeah.
difficult to use it. So we are using the otoscope, which we can only see, that the camera can't see.
Okay, so he was referring to some very
Yeah.
cheap device.
Yeah, that can be used in adults, not in pediatrics.
I am using, sir.
Hmm?
I'm using both.
Both.
So how
Whatever
are
I
you,
find
Shyam?
comfortable.
You can tell us more about it when we are waiting for Deepak.
I will put a photograph in the group of that instrument. Okay.
So how is the clarity, sir? How is the clarity?
Very good. Very good. Any
Okay.
endoscope, like any endoscope,
Ah.
you can go into the nose, you can go into the throat, you can go into the throat. It will be traumatizing, but you can go in the ear, nose. It's an doctor endoscope. I will let you have the name as well. Huh?
Commercially
You're able to
available?
use for less than 1
Yes,
year, sir?
online. I bought it online.
So less than 1 year, sir. During for infant, you are able to use it, sir. For infant.
I have used till 1 year at least.
Hmm?
For those who has calm child, I have used till 1 year, or not below that.
Ah, that is the thing, yeah. Because usually the common thing is we get otitis media less than 1.5 years. That is the age group we commonly get.
What a beautiful picture you get, sir. You cannot think of it. Once you start using it, you will not have the option to use that oral this otoscope, your handheld otoscope. Once you start using it, you will get such a beautiful view. I will send the name of that company, okay? And I even the photograph of that. Upload in the group, both group.
Share it, sir, in the group. That's enough. Mama?
Hardly cost 1100 or like that.
Mm-hmm.
And it can be connected to your tablet, your Android phone. But I so far I could not connect it with my iPhone. Maybe Apple has some limitation or whatever.
Bluetooth connection.
No, that you put into the hub of this C side. What is that connection port? You insert your charger point. That from there you connect it. It will the light will start and you
It's
will
wired. It's wired.
very good, very good. Performance wise, you see everything crystal clear. And in law, you can save the pictures for future reference, and you can share to the patient as well in his phone for future reference. Like you give the report of any lab report, you can give the picture of that. So see the healing. You can recall for the healing whether it is healing or not. I saw.
So, Nawaz, you can ask for the club. Now it will come. Nawaz?
Yes, sir. Sure. I'm asking, sir.
Now you can present.
Yes, I have got that access. I'll present. Yes.
You ask for those.
Yes, I have asked, sir. Yes. Hello, doctors. Good evening. This is Nawaz from this side. So I'm the technical person from IuSync. We are a digital stethoscope company spun out of IIT Bombay. So today I'm here to discuss and demonstrate more about how AI-enabled digital stethoscope is helping pediatricians in periphery auscultations and to early diagnosis of diseases. So first, I would like to show you. Start with the PPT here. I hope it is just a second. Okay. So straight away we'll go with the device. Okay. So doctors, so when we started, I'm holding one of our device. That's a digital stethoscope. So it started from IIT Bombay. So there's a department called BETIC there, Biomedical Engineering Technology Innovation Center. Every year, doctors bring the problem statements there, and we as engineers, we develop solutions for them. So one was basic auscultation. So a lot of doctors, the main problem statement was, can we transmit
Avas,
auscultation?
can you make a little bit mic near so that be louder?
Sure, sir.
Voice
Sure.
is not much.
Definitely, sir. Definitely. Sir, I hope I'm audible now clearly. Yes. So
Yes, sir.
one of the problem statements was transmission of sounds from one place to another place. When we started doing that, so we got multiple problem statements. There were total 6 problem statements to be precise. One was starting with subtle sounds in infants or babies. So how to clearly listen to them? So this was doctor's request key. Can you build something for that? And second is background noise in NICUs and busy OPDs. There'll be not lot of machine noise. So can we reduce that and we clearly hear heart and lung sounds? And a few of the doctors were requesting for Nawaz or one of us, our CEO founder, Mr. Adarsha. So when we tend to hear sounds, we tend to hear both heart and lung sounds. So can you build an algorithm where we can specifically focus on heart and specifically focus on lungs? So, and then some came with the challenges key. When we tend to auscultate, babies don't cooperate. Do you have something for that? And can, if I'm not available in the hospital or the clinic, can my staff record and generate a report? Can we share it to some other person? And the biggest elephant in the room is AI. So can we use AI to detect some abnormalities? So that is what, after 2-3 years of R&D that we have developed, I'll just straight away show you our device. Okay. So I hope you can see me. Okay. Yeah. I hope I'm visible to you, sir. So this is the device. As you can
Yes,
see, we have maintained the traditional spirit of stethoscope. Okay. So why we have maintained this traditional spirit of stethoscope is, so doctors didn't want to lose the feel of using stethoscope. Okay, all these years, after 100 years, that the conventional stethoscope that we have been using. So this is what, and as you can see, there's a module here, digital module. This is where all the amplification or digitization happens. So the first problem statements that we had was amplification of subtle sounds. So what we have done, we have simply put an amplification dial here. So with this, whenever there is a subtle sounds which are not able to hear, so doctors are able to amplify those sound up to 60 times. And it is very subjective again, where doctors can auscultate according to their convenience and listen the sounds with very much clarity. And the second thing comes is noise reduction. The biggest challenge that doctors face is noise reduction, especially when they're dealing with infants or babies. They're crying noise, okay, the other OPD, busy OPDs. So we have put noise reduction here so that automatically the background noise will be reduced and the algorithm puts forward heart and lung sounds very clearly. And the third is uh, uh, background noise cancellation is, and third is heart and lung filters. So doctors specifically ask, can I hear heart more? Can I hear lung more, to identify the abnormalities? So what we have done, so I'll just simply show you. I'll just switch it on here. So you can see there's a pink light glowing here, which means it is in heart mode now. So now the entire stethoscope is in cardiac mode, where you can straight away just go and straight away auscultate on the babies or the patient, and you can slowly start amplifying this, right? So you can amplify according to your convenience, and if you are done with the cardiac mode, you just have to double tap here. Okay. So now it is in pulmo mode. Now what happens, the algorithm reduces the heart sounds and puts forward lung sounds more. Now you'll be able to identify abnormality in lungs very clearly. Okay. So this is about the hardware. Now, the fourth problem statements, doctors, was, can I auscultate without this tubing? Or can multiple people auscultate at a single time? So that was, so what we have done, very simple. And we can remove this tubing. We don't need the binaural now. And you can connect any Bluetooth headset to it. Any Bluetooth headset. You can auscultate just by keeping this on the baby or the patient, right? So this is one use case. Second use case is, now a lot of doctors requirements request was, so patients, especially babies, they don't cooperate. Okay, they cry, they have stethoscope anxiety, and they see something and they cry. So what we have done is, the bestest use case is, you can hand this over to the parent, and the parent is holding the baby. You just have to show the position. Okay, just keep it here. Now baby is very calm. Doctor sitting from a very long distance, even 10 to 15 meters, can listen it. And in very busy OPDs and wards, some other duty doctors can go and auscultate. The senior doctor can sit and listen. Now the fourth thing comes, that is report generations, doctor. I would like to show you our application. Just a second. I hope you are all able to see my screen now.
Yes, sir.
Yes. So this is our application where multiple things will happen. One is not just recording and sharing. We can also generate a report here. That is how I'll show. Now there's a scenario where doctors, you are busy and you're not available in the hospital. Now there's a critical case at your place. Now, can your D2 doctors or the nurses, can they generate a report by recording this one? Yes, it is possible. You just have to click on heart sounds here. All the four areas, aortic, pulmonary, tricuspid, mitral, in each area, we can record for 10 seconds. I'm just showing you for 10 seconds recording, please. Done. So similarly, we can record on all the four areas. You can see the loved up amplitudes there. And we have put digital case generation facilitation here. So instead of maintaining all the records on a piece of paper or something, so what we have done, we have put a digital case report generation where two things are very mandatory, that is age and gender. Okay. So we have not put any space for mentioning the name. Again, Dr. Krishnan sir has mentioned according to the DPDP Act and HIPAA compliance and all. So the patient health identifiers we have not put. So thus age and gender is enough. And you can maintain their other basic vitals like BP, temperature, SpO2, the general problems they come with, heart problems, lung problems, your diagnosis, treatment summary and notes. Now, once you save it, report generation will start. Okay. So I'll show you a very beautiful reports, doctor. This is one of a report of a doctor himself that we have auscultated. So you can just go here. So you can see all the four areas. Now, the first thing that we can analyze here is we can actually play these sounds. Okay, we can listen and play these sounds. Okay, and we can reduce the speed, especially when babies have high heart rate. So we can reduce the speed here. We can amplify the sounds and listen it very clearly. And you can see there are a lot of information here. So first is you can understand the beats per minute. With this, the enough data of tachycardia or bradycardia will be identified. Next, you can see murmur is absent and hypertension is absent. It is showing here. So how it is happening, if there is any, so this algorithm detects S1 and S2 sounds. If there is any added S3 or S4 sounds, that it will consider as murmur. And if there is P2 sound in heart, if it is very loud, so that when it considers as hypertension with confidence levels. Now the question comes is, how you got this confidence level. So we did clinical trials in Kokilaben Dhirubhai Hospital in Mumbai and Narayana Hrudayalaya in Bangalore. So based on that clinical trials, we are giving these confidence levels. Now to identify this, we just have to click on graphical insights. This is my personal favorite because I'm not from a medical healthcare background, but even then I'm able to understand this very clearly. So as you can see, doctor, we have put phonocardiogram with color coding. So here we have given S1, S2 systolic diastolic phases. So here, so each and every colors we have put here actually. So S1 is for yellow and all. If any abnormality is visible here, doctors, can be seen in a red indication. Any abnormalities, any third sound S3, S4 is adding. So this is how we can actually see where exactly the murmur or abnormalities originating, progressing, and deteriorating. So this is how it is done in heart. Similarly, we can just go to lung sound, 16 auscultating areas, anterior, lateral, posterior. We can choose whichever we want, record that position for 10 seconds, and save in the same patient case sheet, and it will give the result. And it will tell you whether which of the position is giving abnormal sounds or not. Okay, so this is about the application that we have, and this entire report actually can be shared with anybody, any doctor across the world. Just you have to use your any social media platform, WhatsApp or anything that you can share. Now coming to one of the abnormal sounds I would like to show you. Okay, so doctors, this is an abnormal. I hope you are able to see my screen here. Okay, sir. Sir, I would request anybody, if you are, can you confirm this if you are able to see, please?
We can
Yes, sir, we can
see
see the screen.
we can see it, but we'd like to hear also.
Yes. Okay. So this is a congenital heart disease case for a 5-year-old kid that we recorded in Kokilaben Dhirubhai Hospital in Mumbai. So as you can see, we have S1 systolic phase, S2 and diastolic phase. And also, doctors, you can see there's a red indication here. There's something red coming here. So that is, we have indicated as murmur. So in this particular case, what is happening? The murmur is starting towards start of S1, traveled whole across pan systole and deteriorated towards S1, S2, sorry. So easily, even if you are not available, your staff, which we will train, can understand this, and they can send you the recordings report, and they can discuss with you and take opinion from you. So it is that easy here. So that is how we can easily identify. And with this, we have actually screened 92,000 patients across India, and around 15,000 doctors are using our stethoscope to in periphery also to detect abnormalities. So this is with the limited time, I'm able to explain you a few things. So any questions, doctor, please, I'm here to answer your questions.
Nawaz, there is a
Yes.
question, why gender is important here?
Okay. So gender, what happened, sir, when we started developing our device, so when we approached doctors, multiple doctors, so there were different questions asked to doctors, what is necessary to keep and what is to remove. So we have solely kept everything based on the majority of agreement of the doctors. So most of the doctors had mentioned, yes, gender you can put, so that we have put. So if there is any serious concern, it's just a matter of 10-15 minutes of app development that can be removed as well. No problem in that.
I think the gender is important because if you're auscultating adults,
Yes, ma'am.
The thickness of the chest wall is very important.
Exactly, ma'am. Exactly. Yes.
Can you tell us the cost of?
Ma'am, cost, usually there are different versions, two different versions. So one is just the clinical version, whatever I have showed you now. There is one more version with one particular feature added to that, that is live streaming of sounds. So if you don't have enough time to record and share, but in critical cases or emergency cases, you just have to keep it here, and you want to, the other doctor from other side across the world want to hear it live. So that is a live streaming option that is available. So there are two different, I'll tell you. The clinical version is called IUSync 2 Plus, which generally starts with 18,000 MRP, but that is the maximum retail price that we have. But we do run different campaigns for doctors where a huge amount of offers and discounts that we run. So I'll drop my phone number or mail ID in this chat. So please feel free to get in touch. If you want to know more about it, we'll be very, very
Please
happy.
share, Nawaz.
Yes, sir.
Please share in our WhatsApp group. I'll
Yes.
forward. And
Yes, sir.
today we had a AI primer in St. John's Medical College in
Yeah,
Bangalore. I am there now. I'm just leaving from there
Okay.
for medical
Okay.
students and faculties.
I understand.
There, our founder of Dr. Dr. Amit was asking about your IUC.
Okay. Okay.
In
Yes. Yes.
September 20th and 21st, you please mark the date, September 20th, 24th.
Yes,
We
sir.
have a International AI Global Summit at Radisson's Blue at Delhi, New Delhi.
Definitely. Definitely, sir. Definitely.
I will send you the details.
Please.
And about our learners,
Yes, sir.
I will send you the brochure, what you have sent, and the videos.
Yes, sir. Sure.
I think within 15-20 minutes, you have given a good information.
Thank you. Thank you so much.
There is some charging problem from Dr. Naveen. He is using your equipment.
Yes,
Dr.
sir.
Naveen, can you unmute and tell? Is there any problem with the charging or?
Naveen,
Yes,
sir,
sir.
please, please.
Hello, sir. I am using this since 1 year, sir.
Oh, okay. Thank you.
Initially,
Thank you.
beginning it was okay, but in recent times, in past since 1 month, I'm getting
Yes.
that issue. Repeatedly
Sir,
discharging
yeah, Naveen, sir, what exactly is the issue? Can I know, please?
the battery getting discharged so fast.
No problem. No problem. Where do you practice, sir, if I'm asked?
In Soraba, Shimoga district.
Shimoga Dinda. Okay, definitely. Sir, it's been 1 year.
Yeah.
Yeah, no problem. We do have replaceable warranty within 1 year. I will
Okay.
make sure tomorrow our technical team will contact you and will replace
Okay,
you with
thank
free
you.
device.
Thank you very much. Thank you.
Yes, thank you. Thank you for raising this.
Thank you,
Okay.
Nawaz. Thank you.
Yes, yes.
I
We'll,
think we
and
have
also,
just half an hour.
yes, sir. Yes.
Thank you for your wonderful presentation. Now
Thank you
will I
for the
request Dr. Gurunath sir to kindly
Sure.
request for the screening the share.
Yeah, Mr. Nawaz.
Yes, sir. Please.
Mr. Nawaz,
Yes.
are you there?
Yes, sir. Please.
Yeah, please stay and during my talk, and I'll have a question for you at the end of my talk or during the talk.
Yes, definitely, sir. Definitely.
Dr. Gurunath sir, please ask for sharing the screen.
No,
Staff
same
will.
message. Host is not allowing sharing this meeting.
Yes, see.
Yes. No, still no. Still, I am not able to share the screen.
One. Gurunath sir, please try.
Same message.
You're getting same message, sir?
Yes.
Sir, now
Yes.
you can try, sir.
Yes,
Now you
yes,
can
now,
try.
now,
Now
now,
you can.
Yes.
Can you see my screen?
Yes, sir. Yes, sir. Please carry on, sir. Just learners, this is Dr. Gurunath Parale, is very close friend of me. Just Saturday, Sunday, I was with him. He's a senior cardiologist from Solapur. He's not only cardiologist, he's a AI-enabled, digitally enabled cardiologist, senior person. We were doing a deep learning course from Indian Institute of Science 2 years back, and we stood out a very top students from that batch. And he is avid learner. His son is a cardiologist. He has a big cardiology institute, and he has a lot of patents on EEG. With a small introduction, I welcome Dr. Gurunath Parale. He has conducted a very beautiful hands-on training workshop for many of the doctors, more than 500 plus doctors in Solapur. Last Saturday, Sunday, I was there. With this caliber, Dr. Gurunath Parale has showed that he can do in tier 2 cities, he can do lot many things as a interested doctor. With this introduction, I welcome Dr. Gurunath Parale, sir. Over to you, the stage. Thank you, sir. Please start, sir. Parale, sir, are you there?
Maybe some internet issues, sir. That's why he may
Yes,
not
yes.
be
Maybe
responding.
slow internet there.
Hmm.
Everywhere there is a problem. There must be rains in the Maharashtra now. Mumbai I heard because Dr. Ashlesha came. Dr. Gurunath, sir, are you there? I'm very sorry today. A lot of technical glitches. I am outside
Sir, you are
traveling.
muted. Gurunath, sir, you are muted. Muted.
Dr. Gurunath is muted. That's why we can't hear.
No, I think he is reconnecting. Dr. Gurunath, sir, is reconnecting. Please wait. I will call him. Is there any issues? He is
My
joining.
screen. Can you see my screen?
Yes, sir. Yes, sir.
Yeah, can you hear
Sir,
me?
maybe your area the internet is slow. You can switch off the video and start presenting.
Okay, fine.
That will give you a bandwidth. Just video, sir. We are able to. Yes, sir. We can make full screen, sir.
Okay.
Yes, sir. Yes, sir. Just
Okay.
make slides move.
Yeah.
Yes, sir. It is moving. We can switch off your video if any problem.
Yes. I'll switch off the video if required.
Yes, sir.
Yeah.
Right,
Okay.
sir. Thank you. Sir.
Thank you, Dr. Deepak, for a nice introduction. Just a disclaimer. I am also a student, maybe only a step ahead of you all, not very much. Okay, the topic that has been allotted to me is artificial intelligence in pediatric cardiology. I am a practicing interventional cardiologist for last 30 years. Though I deal with adult patients. Yes, I do deal with pediatric patients in a good amount, I would say, because I've been the only cardiologist in this area for initial 10-12 years of my practice, and whole district, all children used to come to me for echocardiograms. So for the congenital heart disease diagnosis, perhaps I have been well versed in the diagnosis of all congenital heart disease. Now, coming to the topic of the day, we'll be dealing the topic of the day under these headings. Now, as you know, there is a tremendous burden of congenital heart disease. Nearly 1% of the live births you have congenital heart disease, and nearly 8 per thousand you have significant cardiac defects. And it is number one cause for the mortality, infant mortality. Congenital heart disease is the number one cause for infant mortality. And this, you must be knowing about this AI, how the various AI algorithms are developed. I won't go into detail, but these all things apply to the pediatric cardiology also in developing algorithms for different cause cases. Now, one of the most important things that we are interested in is the diagnosis of congenital heart disease. Now, here I would like to say this is AI is arriving. I am not saying it has arrived in pediatric cardiology. It is arriving, just maybe putting its foot inside, and we are still in the research phase in most of the cases. In some cases, perhaps it might be just knocking the doors for clinical applications, but still we are not there. But this talk is more to stimulate you so that we can develop algorithms on our own by collecting data and solving this rather grave problem of pediatric heart conditions. As you know, coming first to the fetal echocardiogram, it is very important to diagnose heart disease in utero. And usually congenital heart disease with a good sonologist can diagnose it from 18 to 22 weeks. Now here AI makes a difference. AI makes a difference because, as you know, there can be tremendous variability amongst different sonologists, different machines, baby positions. So here, Now models have been developed where now when you use echocardiography, AI in echocardiography, you have two conditions to consider. Means that two things are very important for AI to come out with a diagnosis. One is it should identify which view it is. This is very important. Unless the AI model cannot detect which view it is, as you know, there are multiple planes in which we record echocardiogram: 4-chamber, 2-chamber, short axis, long axis, aortic long, and so on and so forth. So first of all, which view it is, unless AI model is able to detect, it cannot make a diagnosis. So the first step in developing AI model in any heart disease is for it to train to identify which view. Then comes the diagnosis. So this is one thing. The second automated important thing in fetal or pediatric echocardiography is many conditions or many diagnoses are operator dependent. With AI model, perhaps that operator dependency can be obviated. Now, the models have been developed. They are still in the research, not absolutely, they have not come into clinical practice, but they have with a very high sensitivity. They have been shown to pick up complex congenital heart disease like hypoplastic left heart, transposition of great heart, then tetralogy and AV canal defects. So this is very important because these conditions carry a high mortality, and some of them, if not detected at birth, we might lose them. But if we can detect them at birth, perhaps they are totally curable, like transposition of great vessels. Now, we have to have two models when we consider AI. One model which would be for screening purpose. Screening purpose, that means there is heart disease or no heart disease. And the second model for the intervention purpose. We are at present in the screening purpose area. We have not reached the intervention purpose. The screening model should be such that it should have a very high sensitivity approaching 100%, because this model is going to tell whether this patient has heart disease, the baby has heart disease or no heart disease. So you should not miss any baby with heart disease. So it should have very high sensitivity. So any screening model, not only in this condition, any screening model, when you develop AI model for screening, population screening, it should have very high sensitivity. It can make over diagnosis, but it should not make under diagnosis. That's the principle. Now, certain assisted AI assistance models have been developed where it guides a non-sonographer also, like move your probe to the right, move your probe to the left for 4-chamber. So real-time guidance systems are also coming into the place now. Now, in prenatal, some papers which have been published, like the one which is quoted below, this is a landmark paper where they showed with the area under curve of 72 to 8, means very high sensitivity and specificity for prenatal diagnosis of congenital heart disease. And this is matched nearly equally by an expert sonologist. So that model is reaching to that level. If we add some other features like maternal history and other features to it, maybe the sensitivity and specificity can be improved. So the sensitivity of CHD detection is comparable to fetal cardiologists by this group they have published. Of course, this has not come into clinical area so far. Now, as you know, the challenge in pediatric echocardiography is it requires very high. If you see, if many even fully trained cardiologists cannot do a good pediatric echo, because this echo needs special training. Then as with any other branch, the babies, as you know, we need cooperation from the babies who are moving, crying, so on and so forth. Similarly, this baby's size changes with the time. So the quantitative measurements which are standard in adult cannot be applied to any particular baby, because it changes with their age and their sizes. Similarly, many times the position of the heart in baby is slightly may not be in ideal position. So the standard views we may not be able to get. If there are associated lung conditions, again we may not be able to get standard views. Then for normalizing the different uh, conditions or different measurements, you have to normalize them. We have to have Z scores normalizing to body surface area. Here, AI can make a difference. Now, most of the echocardiography algorithms which have been developed, they have been developed in adults and are gradually being introduced in the pediatric age group and are being validated. But still, I don't think they have come into clinical practice. But whatever the algorithms, now this is one group, this group which has published in frontal radiology, they have, as I told you, they 28 echocardiographic views. This model can then accurately diagnose 28 echocardiographies. And when this is done, nearly 80% work is done. If the AI model can recognize which view it is, whether it is a 4-chamber, 2-chamber, short X-ray, or whatever it is, then I think more than half the work is done. Then after this, they have found with a very high accuracy, around 92%, they can diagnose different types of congenital heart disease. This is very important because if AI model can diagnose this, then it can help the surgeon for preoperative planning. Now, these different researchers have published their papers in different areas. The first is automated congenital heart disease diagnosis. The second, for the non-invasive diagnosis of PDA. See, in a premature infant, PDA is very much common, and many times, if the echo is not available, and if you miss that diagnosis of PDA, we might lose that premature infant. And it is many times a treatable, curable, pharmacologically treatable condition. So if we can pick up, diagnose that condition non-invasively, that will be very useful. Now, other is for the many there are conditions where you have to find the right timing for the surgical interventions. Then sometimes we know some VHDs close, some VHD don't close. If we can develop a model that which VHD is likely to close, which VHD not likely to close, then that would be very useful. Similarly, personalizing treatment of PD also, if we know beforehand which PD is going to respond to pharmacological methods and which is not, that also would help. So the AI models have a different, we have a different scope in pediatric cardiology to develop AI models. Now, Nawaz, he said he has presented his stethoscope. Now, this is a similar stethoscope. This is a similar stethoscope that has been developed. But here, there is slightly more advancement because depending on the murmur, they have developed an algorithm that they can arrive at rough diagnosis of congenital heart disease. So this is a one step ahead. And I think this group, IIT group, Mumbai group, can proceed with their so much data because they have collaboration with a good hospital like Narayana, who have a tremendous load of congenital heart disease. I think, Nawaz, you can proceed with this for the diagnosis because this would be very important. This is just having to know whether it's abnormal sound or no abnormal sound will help partially. But if it tells you that this murmur is a physiological murmur or a pathological murmur, because you can have a physiological murmur in babies called as a Still's murmur, especially in adolescents. Okay, or in hyperdynamic circulations also have physiological murmur. If you can distinguish that to a pathological murmur, that will be a tremendous screening. It help in screening and triage and early pickup even in a peripheral center. So I think this might give you an idea to develop it further. Coming to then other tools have been developed like pulse oximetry is a screening tool whether there is desaturation or not. But if you can couple pulse oximetry with ECG with clinical parameters and perhaps a stethoscope of Mr. Nawaz, then perhaps we can improve the diagnostic accuracy of picking up congenital heart disease. Now, one group has shown that ECG can diagnose with a high sensitivity critical serious congenital heart disease. So these are different studies which have come there. Now, one of the groups have shown that only on X-ray you can diagnose what human eyes cannot see. The AI model can see on X-ray whether it is a congenital heart disease, whether there is a pulmonary plethora, whether there is pulmonary blood flow reduction. So it is a pH case, increased pulmonary blood flow, so and so forth. So and definitely human eyes may not be able to pick that, but the AI model will be able to pick that and can pick up certain congenital heart conditions. Similarly, we know there are many syndromic cases with many congenital heart disease having specific facial features. So if an AI model is developed on facial features, then associated congenital heart disease too can be diagnosed in this area. So we can have a diagnosis as well as a risk stratification. Which VHD is likely to close? Which VHD can close early? Which VHD will close later? So when should we intervene? That will help. Similarly for PDA, I told you. So we can have a personalized treatment. Which VHD we need to intervene either surgically or non-surgically and close it, or which VHD we can wait for up to the 5 years so that it can close. Similarly, PDA, which would need pharmacological closures, which will not need closure. So we can have individualized treatment. From echo, we go to MRI. Now, MRI is a very important tool for congenital heart diseases. And here, AI models can be better than humans because the time can be saved. The segmentation time can be saved. Similarly, the measurements, volumetric measurements, which can be done in minutes compared to the humans, which can take hours. In fact, it has been shown that MRI is useful in picking up early ventricular dysfunction, both before the surgery as well as after the surgery. And this can prognosticate the surgical result, because if there is a left ventricular dysfunction before the tetralogy of Fallot, then these babies may not do well. So, and this echo or a human eye cannot pick up, but MRI can pick up that early left ventricular dysfunction by quantifying the strain abnormality. Similarly, CT. If AI is coupled with CT, you can reduce the contrast dose. You can reduce radiation dose. And so the babies who would be very much susceptible to radiation, especially they have to undergo repeated CT in a complex congenital heart disease, then perhaps this might matter, reduction of the radiation as well as the reduction of the contrast. Now is ECG analysis. This is my favorite topic. ECG analysis. So far, again, the ECG analysis has been mostly in the adults, and many algorithms in adults are there who are now, some of them are coming into clinical arena for the diagnosis as well as for the prognosis. But certain congenital conditions like hypertrophic cardiomyopathy, atrial septal defect, long QT syndrome, etc., and ventricular dysfunction, there are algorithms in place which can be applied even to pediatric population. Then similarly, if you have the ECG recorded and transferred over the net to a cloud, and if you have algorithm in the cloud, then definitely even in the absence of the cardiologist, the diagnosis, especially the critical condition arrhythmia diagnosis, can be made. And many times these certain fatal conditions like arrhythmogenic right ventricular dysplasia, Brugada, if we are able to diagnose them, then we can save lives. In fact, I have developed this model for silent atrial fibrillation in adults. I have not tried, because atrial fibrillation is not a common entity in children, but in adults, this model is performing very well, and for which I have filed a patent. This is another model this is an adult patient, and if Mr. Nawaz is there, I want him to be listening to these slides.
Yes, sir.
Yeah, now this is a model which I have developed for left ventricular function. Now, normally you measure left ventricular function using what everyone knows as ejection fraction. Okay, ejection fraction, and that's the standard. But this is a now new parameter which is coming up called as global left ventricular strain. This called as GLS. Now, this GL advantage of over ejection fraction, it is operator independent and it is load independent. That means if I do echocardiography or someone else does echocardiography, this GLS value hardly change unless EF. Now, unlike EF, if you see two cardiologists do echocardiography of one patient, their ejection fraction changes. Now, it does not hold true for GLS. Similarly, if EF echo is done today and echo is done 2 days later, the EF might change because of the loading condition. However, GLS does not change. So this is a very important parameter of left ventricular systolic function. Now, I have developed this AI algorithm for measuring GLS, and this is the first time in the world. To give you an example, now to say the GLS value, anything which is more than 16, forget about that negative value. Anything which is more than 16 is considered normal. Anything which is less than 16 is abnormal. Now, this patient is ECG. Normally, GLS is measured on echocardiography. ECG does not measure GLS. Now, I have developed this algorithm to measure GLS on ECG. As ejection fraction, we measure on echo. Similarly, GLS also measured on echo, but I have developed this model to measure it on ECG. Now, this patient presented to me in last year, January, with left ventricular dysfunction. See, the EF was 33%, and I had a very low GLS. The patient had dilated cardiomyopathy. This patient who had a low GLS, in 7 months' time, there was mild changes in ECG, but the GLS had normalized. The GLS was normalized on my model, the predicted GLS, my ECG. I was surprised. How can dilated cardiomyopathy patients echo become normal or left ventricular function become normal? And perhaps I thought my model is making a mistake. It is wrongly saying that the GLS has normalized. So I subjected this patient to echo again, and indeed the EF you will see is 55% and GLS is normalized. So my model is performing exceeding well. Now, this prediction of ejection fraction on ECG, the model is there in Western world, in US. The model is there in US, but there is no model anywhere in the world to predict GLS from ECG. Now, Mr. Nawaz, using the model of ECG based model for ejection fraction, they have developed a stethoscope. Okay, they have developed a stethoscope, single lead stethoscope, where you can record a ECG with stethoscope, a single lead ECG with a traditional stethoscope. And with that, you know what is the heart function. Okay, not only murmurs and this thing, the heart function you can know, and especially patient coming in the emergency room with breathlessness, there and there you will know from that stethoscope whether this breathlessness is because of heart or whether it is because of the lung. This is very important. This stethoscope has been developed in the Western world. So my appeal to you is, now I have developed a model for measuring ECG based left ventricular systolic function. Can it be coupled with a stethoscope? Yes. If it can be, it would be unique once in it would be the first time in the world that this can be done, because this GLS measurement is, I have already filed a patent for it, because that is first time in the world that GLS using ECG is there. So if we can come together and develop an application, so that would be it will be totally revolutionize the management here, especially in a resource limited setting where echocardiography is not available. Just on ECG, you will be able to tell there is left ventricular dysfunction or not. Now, coming to the next area is the surgical planning. Then, if there are many papers which have come where, because the surgery especially in a complex heart disease is really complicated, and you cannot have surprises on the table. So you have to have anatomy very clear, and despite echocardiography, MRI, CT, in a complex case, the anatomy may not be very clear. Here, AI can come to your help. It can generate a 3D model for the surgeon so that he can plan preoperatively his steps and avoid unnecessary surprises on the table. Similarly, AI models have been developed for predicting outcome of surgery, prognostication. So which patients may not do well after surgery, which patients will do well after surgery, to decide timing of the surgery. So this all can be done using different parameters, uh, depending on maybe baby's weight, height, ventricular functions, ventricular volumes, symptoms, ECG, oxygen saturation, and these multiple criteria can be used to develop AI models. So this is what all theory. But where are we today? What is the current state of AI adoption in pediatric cardiology? At present, only echocardiography is just knocking the doors, and ECG in some. In adults, yes, if for lip function and arrhythmia, it has come in, but for pediatrics, it is still waiting for the validation and then AI approval. For echocardiography, yes, for it is definitely maybe just around the corner, and we may have echocardiography AI tools available in near future. For cardiac arrhythmia, still it is going to take time. For surgical planning, yes, certain cases it is still there, but still it will take some time for it to become fully useful. Of course, there are challenges which all have discussed before, because of the motion artifacts, age, and all those factors, because of the changing sizes of the babies. This all will there. So the road ahead has a tremendous potential, but it is going to take long time, especially in a pediatric setting, for the AI models to be adopted, to become reliable, and to come into clinical area. Thank you.
Thank you, Parale sir. I think you have given a comprehensive review about what are all the tools which are there for screening and for diagnosing. Maybe we need a lot of pediatric data sets, cardiac data sets, wherein we are lacking. Maybe in the next year, I think we can able to make a lot of predictions of congenital heart disease by using a digitally AI-powered stethoscope with the ECG. I think things are going to evolve a lot. Probably what we learners has to think about Dr. Gurunath Parle's the work he is doing with this is practice, heavy practice. I think we have to learn a lot from him. Age is not the bar to learn any technology. That is my main motto. The thing, because since last 2.5 years, I know him how efficiently work to learn. Whatever may be the age of the person whom he meets, he comes to the down to earth and he learns a lot. And he learns till he gets satisfied. That is what. Otherwise, he doesn't leave. So he has struggled a lot to achieve this. This is not come in one day or anything, because when he presented his organizing chairman lecture in his AI summit in Sunday, we burst into tears by listening his capacity. The family, his hospital staff, his supporting staff has supported him a lot, and with this he achieved. I think I should thank uh, from this Smart Hill Nexus Academy, and also I think there, sir, to move ahead, because this is not our police stop. After this course, still we will be in the community and we will be in touch to learn. Any questions from the audience, learners, regarding
Deepak
this?
sir, with your permission, I just have to mention to Gurunath sir as well. Since you both of you mentioned ECG with stethoscope, we do have developed a very innovative device with Dr. Gurunath sir mentioned about single lead ECG, sir. We have developed 12 lead ECG along with a stethoscope. We are working on to implement EMAT in that electromechanical activation time, along with which we can definitely determine ejection fraction. So I would definitely like to connect with you and show you what we have developed and learn more about you and collaborate with you and work. So I will get your contact from Dr. Deepak sir, and hopefully we can work more on this, sir.
Yeah,
Sure,
yeah,
Nawaz.
yeah.
Yes, thank you,
Yeah.
thank you.
So you can just Google Dr. Nawaz Gurunath Parle Solapur Spandan cardiac care. You will get the details. He's in
Definitely, sir.
LinkedIn also.
Definitely.
There is a question in the chat box, Dr. Gurunath. AI cardiology prediction module, can it be available for common people? Any idea regarding this? Any prediction models?
At present, as I told you, only validated model which has been FDA approved, US FDA approved, which has been developed by Anumana with by Mayo Clinic in US, and that is for left ventricular function, which has undergone trial. Okay, that's undergone a randomized trial, and that has been approved there. But I think this still it is proprietary with Mayo Clinic. It is not freely available to us. That is the only. Other are all in the research areas.
But I asked regarding Narayana Heart institutes, various across the mainly in the Karnataka state, they are not giving the data. That is the main
Yes,
problem.
that is the problem. Unless you
That is
have
the
data,
problem. Otherwise, you would have been
that is
given by nowadays lot of things to be picked up by cardiac congenital cardiacs. So these Narayana
yes,
people are
I
not
think,
giving
but
the data.
they have some team working. I think I have heard that they have a team of engineers working and developing their own indigenous models. That
No,
was
sir. Still, they are doing
I tried to
electronic
contact them
digital
with what.
record.
Huh.
Because last month I attended a AIH conference in Lila Palace, where I came across this Narayana people. Still, they are working on electronic digitalizing the data regarding the prediction models for like your cardiac invasion. Also, they have not done. To be frank with you, I'm little bit
Yes, because I was in touch with one of their chief cardiologists, Dr. Deepak Padmanabhan, and we were thinking of collaborating
Yes.
with Narayana, but somehow again that, as you said, that hurdle
No,
of
because it
data
is under
sharing
the
is an issue.
proprietorship. The proprietor of Narayana, Dr. Devishetty, is not allowing his team.
Is not, yes, that is the
That is
issue.
the main problem. It's a more of a ego issues rather than the uh, other things. It matters a lot.
Yeah.
It's okay anyway. It's a part and parcel of the business. But we are not in the business. We are there for the welfare of the community and share the knowledge. I think, is there any other questions from any audience? I think we had a very fruitful session of pediatric cardiology, though we are in an infantile stage, pediatric allergy, but it has ignited a lot of research gaps in your mind as a pediatrician. So probably we are ending this specialty series now, and Saturday, Sunday, we are going to join with the research methodology and manuscript writing in the regular 5 to 7 o'clock, not in the night, because some people were tired, they are telling. I'm very sorry for that, because to adjust the faculties and all, it is very difficult job to conduct a 2 batches simultaneous course. Anyway, thanks a lot. Thank you, Dr. Gurunath sir, Dr. Krishnan, RAJBHAR,
Thank you.
and Mr. Nawaz from Ayu Singh. I
Thank
will
you,
send
sir.
the details of Ayu Singh and all. If you are interested, please contact them, take one-to-one demo, and please use digital. I have 3 digital stethoscope in my hospital. Our nurses are very fond of, they're using it. They're sending me the Bluetooth, via Bluetooth, the signals, they're sharing it. All those things, they are doing it. I think with this, we'll make it a day today. Thank you very much to all of you. Good night. See you. Bye.
Thank you, doctors. Thank you so
Bye-bye.
much for the opportunity.
Bye
Thank
bye.
you.
Thank you.
Yes, yes, madam.
We really appreciate your commitment, and though we are also staying up late, it is so much more taxing for you. We really appreciate
Thank you, madam. I'm traveling, madam. I finished AI primer in St. John's Medical College.
Yes,
I'm
yes,
coming back to home, madam. But still, I don't want to leave you people alone just by postponing and all. I requested faculties, they also cooperated, and you people also cooperated. That shows your zeal and learning, madam. Thank you.
Deepak sir, one comment.
Yes, Jalil sir, please.
Sir, excellent topic by Gurunath sir, because the new terminology used, the GLS versus the ejection fraction. The only thing is the prediction module is available freely. Then it is very difficult for the practitioner. They will.
Sir, it will come, sir. It will come. Only thing you digitalize, you send your echocardiograph report, then we can able to give the good model.
I asked that question, number one. In the
Yes.
lung area, anterior and posterior has to be auscultated, which is, I think, not mentioned in his talk.
Yes. Yes, sir.
He did mention. He said 16 places he puts the stethoscope. So he showed 8 in front, so 8 is at the back, or he showed 6 in front. So probably
There is a model for Anganwadi workers, madam. It's called swasa.ai. Swasa. SWAASA. Swasa.ai. It is mainly to identify by breathing sounds around 10 to 15 diseases it can pick up. Swasa.ai.
Okay, thank you.
Unfortunately, I could not able to get them. Otherwise, I could have demonstrated. Let me see in the next free live webinar. I will contact them.
Yes, and I hope we will be able to attend your webinars even after.
No, free webinars will be there every month. There we give every month free updates. Okay, we are not going to leave you unless you should leave us. That is what. Okay.
There's no
So next
choice.
Saturday, Sunday, 5 o'clock to 7 o'clock, be ready with important topic, academic research. Every single clinician or a corporate level clinician or a medical college clinician should aware of, because of AI tools, you can do easily research. You can pull out the papers, you can do research, and you can write the manuscript and you can publish it. So myself and Dr. Rihan Yaqub from Pakistan, we both are engaging you for 2 hours on Saturday, 2 hours on Sunday. Please come and attend. Thank you.
Jalil sir, please
you.
feel free to get in touch. I would like to clarify your doubt, please.
Yes, please.
Yes, thank you.
Thank you. I will share your number, Nawaz.
Yes, sir.
Okay.
Thank you so much.
Please contact, be in touch. Don't worry.
Definitely.
Okay.
Definitely.
Try to bring newer innovation in IOSync. We are there, and we will meet you again in New Delhi Global Summit. I'm going to send the invitation. Please participate.
Sure, sir. Sure. Thank you.
Don't worry about sponsorship money. Our founder has told we will give them a pod to present it, irrespective of we are not going like other business thing. He has already said, okay, we'll give you the platform now, sir.
Thank you, sir.
Thanks a lot. Thanks a lot. Good night.
Good night.
Bye. I will end the show. Thank you.
Welcome.